Hello, this will be a neuroradiology case discussing the differential diagnosis of cervical intramedullary enhancing lesions. My name is Lubdha Shah. I'm a professor of radiology at the University of Utah in Salt Lake City, Utah. Our case is a 54-year-old male presenting with neck stiffness for approximately 1 year. He had increasing numbness in his fingers and difficulty with fine movements such as buttoning up his shirt. He experienced unsteadiness while walking, having to use a cane. On clinical exam, he demonstrates hyperreflexia in his arms and legs. MRI of the cervical spine on this patient demonstrates T2 and STIR intramedullary hyperintense signal spanning 4 vertebral segment lengths. There is horizontal intramedullary enhancement at the C5-C6 level. The axial T2 weighted image demonstrates intramedullary hyperintensity. The axial post-contrast image demonstrates intramedullary hyperintensity involving predominantly the white matter. Our differential diagnosis for an intramedullary lesion that demonstrates enhancement and T2/STIR hyperintensity is an infarction, an infectious/inflammatory process, demyelination, metabolic process, neoplasm, and degenerative process. Let's review some imaging examples of these differential diagnoses. Ischemic injury of the spinal cord accounts for approximately 6% of acute myelopathies. The causes are numerous, the most common being atheromatous disease. Here we see a sagittal T2 showing intramedullary hyperintensity within the conus. There is corresponding diffusion hyperintensity on the DTI sequence, and on the axial T2 sequence you can see predominantly gray matter T2 hyperintensity. The anterior horn involvement with spinal cord injury is reflected by the fact that the anterior spinal artery supplies approximately 2/3 of the spinal cord. Abnormal intensities in spinal cord ischemia typically start in the region of the anterior spinal artery and spread to the adjacent white matter. The patterns of MR signal abnormality with increasing changes reflect a temporal sequence of ischemic changes. We may see them involving the gray matter and eventually involving the entirety of the spinal cord. Often the MRI appearance is a mixture of pattern. Our next differential consideration is an infectious or inflammatory process. This patient presented with acute flaccid paralysis after a viral illness. These patients may have cranial nerve dysfunction or rhomboencephalitis. Acutely on imaging, there is gray matter involvement over multiple vertebral lengths. Subacutely, the imaging pattern is more distinct for involvement of the anterior horns. There may be ventral root enhancement. This entity of acute flaccid paralysis is often seen after viral infections with enteroviruses. Our next consideration for an intramedullary enhancing T2 hyperintense lesion is a demyelinating process, the prototype being multiple sclerosis. Lesions in multiple sclerosis can involve any cord segment, although the cervical cord is most often involved. 10 to 20% of multiple sclerosis may only have cord involvement. The classic multiple sclerosis plaques rarely exceed 1 to 2 vertebral bodies in length. They are ovoid in configuration and may demonstrate homogeneous nodular or ring enhancement. Enhancement rarely lasts more than 1 to 2 months and is seen in the dorsolateral aspect of the cord. In late stages of the disease, the spinal cord demonstrates volume loss, which correlates with disability. Our next intramedullary consideration is a metabolic process. Subacute combined degeneration involves the dorsal columns. Patients present with paresthesias and proprioception loss. This occurs in the setting of severe anemia, such as megablastic anemia. Anything along that pathway that allows methylmalonic acid accumulation causing myelin toxicity results in demyelination of the dorsolateral spinal cord. So vitamin deficiencies of B12 or copper or nitric oxide toxicity affects this pathway and can result in demyelination of the dorsolateral spinal cord. Interestingly, the neurologic findings may precede the anemia. When we see a space-occupying expansite lesion of the spinal cord, it is important to consider neoplasm. Ependymoma is the most common adult primary spinal cord tumor. They tend to be well circumscribed, multisegmental, with enhancement and fusiform cord enlargement. Look for the hemosiderin cap at the cranial or caudal ends, called the cap sign. This can be a very helpful diagnostic feature. These lesions are also associated with polar or intertumoral cysts. The second most common adult spinal cord primary tumor is astrocytoma. These lesions tend to be more infiltrative, expanding the cord with asymmetric or even exophytic growth. They are often multisegmental and may also have associated cysts or syrinx. There's always an enhancing component, which is the site for biopsy. Our final consideration for an intramedullary enhancing hyperintense lesion is a degenerative process due to severe spinal stenosis. Static mechanical factors such as osteophytes anteriorly and ligamentum flavum thickening posteriorly can cause direct compression of the cord. These static factors can aggravate damage with dynamic motion. The severe stenosis can lead to venous ischemia. There's thought to be cord damage due to free radicals. This can lead to an imaging appearance of intramedullary hyperintensity and patchy cord enhancement. The final diagnosis for our 54-year-old gentleman with progressive upper extremity pain and weakness is degenerative cervical myelopathy. It's important to note the enhancement pattern with cervical spondylosis. The typical pattern is circumferential, sparing the gray matter, although there may be a spectrum of findings such as involvement of only the hemichord or single focus of enhancement. The enhancement can resolve after surgical decompression, as noted on the post-contrast sagittal image on the right. The intramedullary T2 hyperintensity can persist for several months after surgery. Thank you for your time and look forward to the next cases.